Okay, we are going to get going here. So, welcome and good afternoon, everyone. Thank you so much for joining today's webinar. Our webinar today is going to be about leveraging Medicaid to advance community violence intervention. My name is Khalees Allen. I'm the Senior Manager for Policy and Advocacy here at the Health Alliance for Violence Intervention. Joining us today will be Kyle Fisher, Policy Director at the Health Alliance for Violence Intervention, Roy Moore, the co-director for the community care team at Healing Hurt People in Oregon, Molly Taylor, prevention and intervention analyst for the community engagement team at the Oregon Health Authority, and Luisa Alvarez, senior program officer for the gun violence prevention and justice reform portfolio at the Joyce Foundation. For a few housekeeping items, so today's webinar is being recorded. And for any questions that people have, there's a Q&A function at the bottom of your screen. There will be time at the end of the webinar where we'll have panelists answer. And so I want to acknowledge today that June is Gun Violence Awareness Month. So this work is really timely. This guide, seems really timely. And that here at the HAVI, we believe violence is preventable and that sustainable community-led solutions save lives. And so bringing us into today's conversation, as states explore new ways to sustain community violence intervention efforts, we have seen that Medicaid is increasingly emerging as a critical opportunity. And so today, to help us understand the landscape and why this moment matters, I'm happy to welcome Kyle to get us started.
Hi, everyone. So great to be with you all today. I am Kyle Fisher. I'm the policy director here at the HAVI. We are really excited today to talk to you all about this new report that we have from policy to practice, leveraging Medicaid to support community violence intervention. This has been the culmination of so much work and so much learning and effort that the whole field we've learned together, and we're excited to share it with you all today. This new report that we have is meant to really help everyone at varying different stages, whether or not you're an advocate or a practitioner yourself. So just a very brief overview of where we're at with Medicaid and violence prevention benefits. You can see right now we are up to 8 states that have Medicaid violence prevention benefits that are either exist or in the process of being created right now. There's a handful of other states that have bills in the legislature or administrations that are thinking about adding benefits. So there's more in the pipeline as well. But what we are seeing is that we're at this stage where we have this first cohort of programs that are the early adopters, and we have some lessons that we can learn from them. And that's what we're really hoping to talk about today with this new report. So why did we create, we've been calling this, if you've been on a Zoom call with us in the last year or two, we've been calling this our user guide that we've come up with. And just want to remind folks that when we're talking about using Medicaid for violence prevention, it is medical billing at the core of it. And medical billing, it sounds silly for me to say it out loud, but it's hard, right? And this is new for programs. Most programs historically have gotten funding through justice programs or through grants. And so this is a new thing, and there's a learning curve that is very real. And fortunately, we have all of these lessons gained from this first generation of programs that are using this funding that we've really compacted and put into this new guide that we're serving. We do want to remind folks that this is just the next in our series of tools that we've created for frontline programs that are trying to get onboarded into Medicaid and using this reimbursement for their sustainability. We have on our website, if you go to the public funding for violence prevention section, we have a financial forecasting tool. So you can plug in your numbers and see how much reimbursement you would expect to get if you were to switch over to Medicaid reimbursement. We have our Community Violence Intervention Smart Hub, which is our repository of different Medicaid policies in the different states, so you can understand how your state might be different than others. And then now we have our next addition to it that you can find on our website, from policy to practice, leveraging Medicaid to support community violence intervention. So this is the big report, and it really is a guide in 2 parts. So I'll just give you a little bit of idea of what is in this report before we talk to some of our folks that are on the ground and doing it themselves. But so this first part of this guide is really a deep dive into the policy itself. What is Medicaid? What does it do? That type of thing. It has a really broad audience, whether or not you're a program or an advocate or a state Medicaid official. We think that you're really going to gain some important wisdom here as you're thinking about doing the right thing for funding your program or programs in your state or local area. With a little bit more detail, this first section, this is just a screenshot of the table of contents. It shows, how Medicaid policies work, what goes into establishing a new Medicaid violence prevention services benefit, an overview of different state policies, what it looks like to have coverage for these programs, how to actually add it, what type of services, what things that you are doing, your frontline violence prevention professionals, what they are doing that would be eligible for reimbursement, because I know you all are doing 10,000 different things. And then lastly, training and certification, which is a big topic that we're always talking about quite a bit. The second part of the program, of the report, really is kind of the brass tacks of like, how do we use this? And this is really intended primarily for the programs themselves that are trying to learn and say, okay, I'm in a state that has this reimbursement. How do I actually do it? So it covers, what this implementation looks like. It helps a guide to help you assess whether or not you're ready as a program to do it, what it takes to enroll and begin the billing process. Some of these questions that you may not have heard about of like, what are these managed care organizations, these MCOs? How do I contract with them? What's that about? And then other kind of more advanced billing and funding considerations. So it really is kind of soup to nuts what you need to get started here. We have added kind of a lot of different tools that we think will be helpful for you. There's a checklist, which a lot of people requested so that it's more user friendly and you can figure out what you need to do to onboard into it. We have case studies and case stories. There's some quick check graphics to look at, what states are doing certification which way, what services different states allow, and then just kind of a state of the field with maps and timelines. We think that this is going to be really timely and helpful for you all, right? I don't need to tell you all this, but I'm going to. The funding landscape is increasingly competitive and challenging. And we know that having more options and for diversified funding streams really helps to promote longevity in programs. And at the end of the day, frontline workers, if you're a violence prevention professional, interrupter, uh, credible messenger, you do life-saving work, and that life-saving work deserves life-saving pay, and we need to figure out how to get folks the payment and the reimbursement that they deserve. So with that, you can send me questions, but we will have questions at the end. I'm excited that I'm going to kick it back to Khalees so we can talk a little bit more about what this actually looks like on the ground and have a discussion with some folks that have actually done this. So with that, thank you very much, and I'll pass it back to Khalees.
Great. Thank you so much, Kyle. That was a really great overview. Thank you so much for walking us through that. So next we will talk about implementation perspectives from a state and community experience with Molly and Roy. So I'll begin with our first question. So many organizations are interested in using Medicaid reimbursement, but may not know where to begin. And so, Roy, what advice would you give programs considering this pathway for the first time?
Thank you, Khalees. And thank you, HAVI, for the support. And I would start with you all. One, finding other organizations that can support you through the process. And as we talk about the user guide and having you all to lean on to get guidance from, first for us was a plus and was our starting point. And so collaborating with you and your advocacy helped us get across the finish line when it came to lobbying legislative elected officials. So I would start there. But ultimately, try to build a strong partnership with the government body. And that's what we got right, I believe, here in the state of Oregon. I have my colleague, Molly Taylor, here from the state of Oregon, who worked closely with us. And I cannot talk about the value of having somebody from the state to work with us, a nonprofit, to really, really capture what it would look like if we're talking about billing Medicaid for the true services that we provide as a CVI entity. So building that relationship, but one, understanding what you want to bill for, and really, really understanding that we want to bill for the true cost of what we do in our case management, showing up to the hospital and providing services for our victims and patients and clients.
Great, thank you so much. Molly, did you want to add to that or?
Yeah, I was just going to say very similar. I think my role as a government employee is just to keep showing up and going to the folks doing the work.
I think there's a
And
little bit of feedback, Molly, on your end. Is anyone else hearing that?
oh, no, goodness. Is that any better?
Yes, it's a little better, but maybe choppy. Can you try again?
Okay, I will try again. I can hear myself
Perfect. Thank
talking,
you.
but okay.
This
I
is
was
good.
just gonna I was gonna say that our work with POIC has been crucial, and I think as a government employee, my main role is to go to the folks doing the work and ask what they need, and then advocate from my role. And that is the partnership that Roy and I with POIC have really developed over the years.
Great. Thank you so much. And so, okay, in building on that, Oregon has been a leader in advancing innovative public health approaches in this manner. What lessons have emerged from the state's experience supporting violence prevention through this Medicaid process?
I'll go first. I think the biggest thing that we've learned is to navigate the
Can you put
unknown
your
with
headphones back
confidence.
on? We're hearing the feedback again.
Oh, goodness. Okay, let me try this. Hold on. Okay, is that better?
No.
Goodness. Any better?
Yes.
Okay. I think navigating the unknown with confidence. And so we didn't have anything to necessarily look for or look to as a duplicative service that's already occurring in Oregon. And so I think our biggest thing was to ask for what we need, not for what we think we'll get. And that was kind of the biggest thing of having a relationship with POIC to really understand the full breadth of the service, so to make sure that the state plan amendment was aligned to the work that's actually being provided.
And if I can just add to that, I think once again, when we talk about something that we found that was unique but was very vital, was the state actually hired a physician, which was Molly's position, to work on this full time, wholeheartedly, to work closely with me so that they had a perspective to really, really meet our needs. And I know that that can't always happen, but I think if you're able to leverage that, then you're able to work as robustly as we did to get some of the asks that we had of the state once again, passed through, but also ambitious asks that we had, and down to our rate, down to what was allowable for us to bill for. I don't know if I didn't have somebody from the state who came and seen the work that we did and spent so much time understanding the work that they would have been able to advocate for us to once again get that approved.
Great. Thank you so much for that, Roy. And we'll stick with you. So from the perspective of the Frontline program, can you share a little bit more about what opportunities and some challenges have you encountered when integrating Medicaid into your CVI services?
Yeah, as those may know and those may not know, it is very challenging to even implement this in what we know as CBI work. And so early on, we knew that Medicaid in itself was scary. We didn't know how to build that. So we established, do we want to try this ourselves or do we want to go after a third party builder? And I'll speak more to that, but that's where we landed at. But something we also really, really strategized around and thought through was the traditional community health worker, because that's a no-brainer to most states. Let's go through that. That's already something that's established and that's an easy entry point. What we found early off is that there's way too many limitations when it comes for the amount of time you can bill, what you can bill for, and then small things like lifetime crimes. We hire credible messengers like many of us all. And so there's a lifetime's crime that will prevent you from billing Medicaid. So that was one thing that we started with. So we said, hey, we're probably going to have to create a brand new bill, i.e., work with the state to create that. Secondly, was do we have the infrastructure as a nonprofit to bill Medicaid? We knew we did not have that, but we knew we wanted to work towards that. So we then said, if we are going to hire a third party biller, let's try to establish a relationship as such as we will hire you to bill for us, but also simultaneously train us so we can also have that infrastructure. And then we said, okay, we need to negotiate the rate that you charge us. And so a lot of people didn't know that you can do that. So they'll give you a flat rate, and we said, let's negotiate that. And we were able to get ours down to a 7% billable charge for that third party biller. These are small things, but these are huge in the big picture of once you are billing, these are going to be the deciding factors of how robust your billing system is.
Great. Thank you so much. And for just for the both of you, what is one thing you wish organizations understood before beginning the process of pursuing this reimbursement benefit? You kind of got into a little bit of that in the last question.
I'll go, Roy, if that's okay. I
Yes,
think the
please.
biggest thing for kind of on the state end is if you're a governmental employee, it's really important that you continue with the momentum of this work. One thing that Roy and I did and our agencies did is we committed to having regular communication, even if there wasn't momentum with the work. And that continued to kind of stay in the forefront of things and also allow for community engagement and community input rather than just seeking community feedback. And so I think a lot of things we did differently. I've worked for the government for a very long time, and I quickly learned that there was a lot of things we were doing because that's how it's always been done. And when I asked, can it be done differently? There wasn't a reason for us to not do it differently. So I think that's where POIC and other folks doing this work played a role because I don't have direct experience, but I can be a strong advocate within the system.
Great. Thank you. And Roy, did you have anything else?
Yeah, I would just add to Molly's point, we didn't know what we didn't know. And so once again, we were ambitious. And so I would encourage people to shoot for the stars and don't limit what you're asking for, because what we found is once you get this through the finish line, you're kind of held to that. And it's hard to go back to legislative body and get things changed, especially in uncertainty around funding statewide, federal funds. And so whatever stage you are in, if you're not quite there yet, shoot for the moon. You never know what you can get past, especially now when the need is there. And then also leverage the work that you're doing to tell your story. Because once again, we're going to have several people that this is foreign to, and they're going to have a lot of questions. Why are we billing Medicaid for this? And so the need for this to be sustained through a healthcare system speaks to skin in the game, but why it's important for us to have lasting impact and sustainable services for victims.
Thank you so much. Thank you so much to you both. Next, we will move over to Louisa and we'll talk about the philanthropic perspective. So Louisa, I'll begin so as funders think about the future of violence prevention and why, can you go into a little bit more detail about why sustainable funding is important and what role can foundations play in helping communities leverage opportunities like Medicaid?
Yeah, absolutely. And thank you so much for having me. And I want to just start by saying major congratulations to the HAVI for getting this report out, this guide out. It's been a long time coming, and this is a big deal for you all. And I want to just congratulate you all on making this resource available to folks. It's really tremendous to have it, and it's timely. I also want to just step back for a moment. These last couple of years, we have experienced the biggest decline in homicides in the country's history. Everyone here knows that. I'm just going to keep repeating it every chance I get because it didn't happen by accident. It wasn't luck. And the investments that cities and states across the country have made in evidence-informed gun violence reduction strategies and community violence intervention are a huge part of the explanation for that reduction. So when we think about the future of violence prevention, right, if we want safe communities, we absolutely have to resource CDI as a permanent part of the public safety ecosystem, right? And that means sustainable, predictable funding. And it is really exciting to be in a moment now where Medicaid is part of that equation. So the Joyce Foundation is a policy-focused foundation. We don't fund direct service work. Our theory of change is that by resourcing advocacy, research, policy implementation, evaluation, we actually move the needle further by making public resources available to support work like CDI and other levers to reduce gun violence prevention. That's asking a lot in the current funding environment. Somebody, maybe it was you, Roy, described the environment, or maybe Kyle described the environment as competitive and challenging in terms of funding for CBI. I mean, that is a very diplomatic way of putting it. I'm sure everyone here has heard a funder say, some of you have probably heard me say, that philanthropy is not going to be able to fill the gaps created by the changing CBI funding landscape of the last few years, which is one of the reasons why I think philanthropy should be so committed to helping communities leverage Medicaid as part of the funding environment. And I think there are a bunch of ways for philanthropy to do that, right? So first off, right, helping to create the capacity that particular communities need in order to tap into this kind of public funding opportunity. I've had the pleasure of hearing Molly and Roy talk a couple times now about the journey that they've been on to get to the point of using the Medicaid benefit in Oregon. You guys describe it with such great grace and poise. It sounds like it was incredibly challenging and at times like an absolute hot mess, right? Like you are talking about creating capacities from scratch in some cases, right? In an ecosystem that's already under-resourced, right? I always come away struck by the amount of real work it takes to ready an ecosystem to engage with the Medicaid behemoth, right? And it's both clear that it's worth it. This is now a durable, reliable, predictable part of the funding picture in Oregon, and right that it requires real shoe leather and real funding. And I think the good news there is that that's the kind of capacity building investment that philanthropy is actually pretty good at. And I like to think that this is the kind of grant making that might really appeal to local or regional funders who don't necessarily see themselves as having a long-term orientation towards violence prevention work. I think anyone here who's applied for a grant from philanthropy for gun violence knows there aren't that many big national funders or regional funders that are really focused exclusively on this. But I think there are a lot that want to see the nonprofit sector thrive as part of safe and thriving communities. And thinking about, the opportunities to do capacity building work to ready the ecosystem to take on, accessing a public benefit like this, I think is exciting. I also think there's a critical role for philanthropy in helping to scale the best practices and the lessons learned, right? Like flagging the potholes so that nobody else falls into the same ones that you guys have fallen into, right? Everybody can fall into new potholes. So it isn't going to be easy anywhere, right? But I think that's something that philanthropy can really help with. I've been a fly on enough walls now to know that every state's Medicaid environment is different. Certain things everyone's going to have to figure out for themselves. But there are also standards getting set, bars being raised, flags getting planted around reimbursement rates and what services are covered that I think philanthropy can and should help elevate, in order to ensure that the folks in Minnesota and Michigan are benefiting from the battles being fought and won in Oregon and California and Illinois, to really set those standards and educate policymakers about what the field really needs in order to really make use of this benefit. And I think philanthropy has a real stake in ensuring that this isn't just getting enacted, but that it's really getting maximized. And I just jotted down, I hadn't realized that actually, Molly, your position was created specifically to support the implementation of this benefit. That's great. That is, that's a lesson learned that, we should make sure we're helping to move around to other states. And then finally, I think there are still some folks who look at the Medicaid picture overall and feel kind of discouraged, right? Like this is a lot of work. It's not easy. At the end of the day, right? It doesn't cover everything. And even for the stuff that it does cover, it's a piece of the puzzle, right? It's not a silver bullet. It's not going to be the answer to CDI funding, in any community. But I think it's essential that philanthropy be inspired by this. It is to the tremendous credit of the CVI field and to you all at the HAVI specifically that a durable permanent resource like Medicaid is now part of the CVI funding equation. And if we can support you all in accessing that benefit and implementing it successfully, in the long run, that frees up philanthropic funding in the CVI space to do what I think philanthropy does best and should do, which is facilitate innovation, absorb risk that the public sector isn't ready or able to absorb yet, and support the field as it continues to push the work forward. And I think the success of the advocacy that's gotten us here should really encourage us to be expansive and creative in our expectation of what public funding for CVI should look like. So I'm so just impressed and inspired by the work that you all have put in to get to this point. And right, 8 states down, right? We have a couple of, I can see who's on the call. I know some of you are coming next to the queue, and just really, really encouraged and think there's tremendous momentum here. I'm gonna pass this back to you, please.
Thank you. Thank you, Louisa. That was really great. So that rounds out our conversation today with our panelists. And so we'll shift over to Q&A. I see that we have a few loaded in the chat, and we did have a question or Q&A in the box, and then we did have a question that was answered in the chat. So I'll just jump over. So Elizabeth has a question for Kyle. So it says, where's the list of states with pending legislation? And kudos to you for this report.
Thanks, E. Always good to hear from you. Yes, each year we still have a handful of states that are actively looking into adding the benefits. Legislation is one way of doing it, but some states are doing it just through regulations and by modifying existing benefits that they have. So I want to make sure we put a big emphasis on that this is a situation where you don't always need to pass a law. And sometimes it's good to just go straight to your state Medicaid office and see what's possible. Also, just kind of note that we are in June now, and we've kind of gotten through state legislative season in a number of states. But in this year, we saw legislation in Washington State, Minnesota. There's still active legislation in New Jersey. In Virginia, I see some Virginia folks on the line. Shout out to the folks in Virginia who they passed a law this year to basically start the process and recognize violence prevention professionals as healthcare providers. So they're part of the way there. And then there are a number of other states that we've been in discussion with about adding it administratively. And so, for example, previously, Pennsylvania has conducted some working groups through their governor's office, though those are still ongoing. And I guess I left off Indiana has released legislation in recent years as well. So still a lot of ongoing work.
Great. Do you also want to share just about our success in Maryland with our learning community and that a little bit, Kyle?
Yeah,
And that
I'd
kind of
love
phase
to.
of our work as well?
Yeah, so one thing that we've found has been really helpful for programs to get going is really to be in community with other programs working through the same thing. Like I mentioned, there's a big learning curve for this. So we just finished our first year in Maryland of convening a learning community. And we invited community violence intervention practitioners and policymakers and anyone that wanted to join in the state of Maryland to work through these issues were available. And so what we found was that there were a number of programs that were interested in switching over and using Medicaid as a funding source. But as we dug into the regulations, we realized that it was really much more stringent and strict than we even initially had on the first read. There are little things in it like place of service codes that kind of said where you could deliver the services and where you couldn't, requirements for affiliations with trauma centers and things like that. And as we got into the weeds on it, we realized that it was hard to hit all of the boxes and still do it. And fortunately, because we had done this in tandem, and the folks from Maryland State Medicaid office were part of this learning community. We had a great working relationship, very similar to what Roy and Molly did, where the state said, okay, we recognize that some of this was a little too stringent along the ways. And so the state ended up revising the regulations and making it more broad and open so that programs could have an easier time billing and getting reimbursed. So it actually ended up shifting our timeline back, but we found out that by making those changes, it's going to be a lot easier and more broad for more states, for more programs in the states to jump in and start getting reimbursed for this life-saving work that they're doing. And so that's the type of thing that we do think is really beneficial, and for folks in different states, a great way to do it as well. In California, there's already a Medicaid working group that already exists. We meet bi-monthly there, and we have our national Medicaid working group as well. So I can use this as an opportunity for folks that want to jump in on either of those as well. Just send us an email.
Great, thank you, Kyle. Yes, all the information can be found on the page that Kyle referenced earlier, where the SMART guide lives, where the map is, and we hope that you join us. And so we have another question. So for any states that have gotten this approved, do you have any concern about your ability to get Medicaid funding given the coming cuts to Medicaid services?
Great question. So what we know is that based on HR1, the quote unquote One Big Beautiful Bill Act that passed last summer, it really did tighten the budgets for states for Medicaid as well as food stamps. That will have trickle down effects to state budgets where it's going to be, when state budgets are tight, it's harder to do everything. It's just kind of the way of the world and kind of a universal truth. On the other hand, when it comes to Medicaid reimbursement for violence prevention, we are small fish in a big pond, to be honest, right? Remember that when we're talking about Medicaid, we're there, but your local orthopedic surgeon is there, community health workers are there, hospitals are there. 20% of American GDP is in the healthcare system, so we're not alone. And so we are a small line item, and on the plus side, no state is going to be able to balance their budget by cutting violence prevention services. So I do think that it is going to be, I don't think that we're going to be the place that states are looking for cuts to balance their budgets. On the other hand, just being realistic and plain with everyone, we know that it is going to be harder to create new spending in places when states are kind of strapping down and trying to tighten their belts. So the degree of difficulty may be a little bit higher. On the other hand, states that want to do this and want to fund violence prevention, this is a way where federal funding, you get federal matching dollars through Medicaid. So it is a little bit of a push and pull. So I think overall it is going to be harder to add new services, but I wouldn't go so far as to say that it's going to be impossible or it's not going to happen. Molly, you are in the state Medicaid offices. You're hearing these budget conversations. Do you have any other wisdom that you'd like to add on that?
I would say just keep having this be in the forefront has been kind of the biggest. I think priorities continue to come and new things become kind of the hot topic. And so it's important to continue kind of moving this work forward and making sure that it's kind of in the forefront still. We had a lot of momentum in 2022 when our House bill passed, and it's really important that we continue to keep that momentum moving forward.
If I could just add, and as a service provider along those lines, similar to being along those lines, what we're doing as practitioners is that our staff is being trained as assisters. So a big part of this, the cuts to Medicaid, is accessibility, and some of the guidelines they're making it harder for people to be eligible. So we're getting our staff trained to be assisters. So we are doing an assessment. Are you on which we have in the state of Oregon, Oregon Health Plan. And if you're not, staff being trained to get you signed up, so we can lower those barriers for our communities.
Police, can I add something there too? Okay. I think I called Kyle with exactly this question when the one big beautiful bill was being signed. And I would just say from the philanthropy perspective, I think there's appreciation that this is not right. This is not a quick fix. I think I have now learned just enough about Medicaid to be dangerous, but one of the things I have learned is that that it takes time, it's laborious to set these systems up, and this is a long-term bet on funding as part of a permanent, durable ecosystem. I think everybody who does this work is in it for the long haul, and I think as we on the philanthropy side who are thinking about how to help the ecosystem access resources, we are doing our best to think about the short term, the medium term, and the long term. And right, folks can't be everywhere. The folks in the advocacy space who are on, who are on the webinar now, right? Your hours are finite. I get that, but as you think about, where what the priorities are around public and policymaker education, I think this is part. I really think about this as part of the long term public commitment to resourcing CVI, and for philanthropy has the privilege of taking the long view, right? We want the public dollars to be there so that the private dollars are available for the short term stuff because we can act more nimbly. But for what that's worth.
Thank you. We had another question. Kyle, will you answer that question out loud? I'm not sure if everyone can see that around 1115 waivers.
Yeah, great question from the audience. And the question was, how have states done this? Have they used 1115 waivers or something different? And so just briefly for the folks on the call that aren't Medicaid nerds like myself, Medicaid really has two different ways to add new benefits. One is through what's called a simple state plan amendment. States that through the federal government have a variety of benefits that are either required and mandatory for them to add, or they're optional for them to add. And so if you have either of those uh, pathways, you can just add a state Medicaid benefit through either of those pathways. And in fact, that's how most states have done it to date. The vast majority have done simple state plan amendments. In fact, I would say all of them to date have started that way. There are a small number of states right now, it's just Illinois, that have created what are called waivers. And waivers are basically health policy experiments for what are called 1115 waivers. And these are an approach that you're able to do new and innovative and different things, but it's an experiment. So it's a time delimited. You have to kind of prove that you are budget neutral. There are a lot of strings and rules to it, and they can get political and they can be really challenging. There's a lot of back and forth between the federal government and the states in getting those waivers approved. And so I say that because most states can just add the benefits through the traditional, easier to go about pathway of a state plan amendment. But other states have taken the next step and have tried out these new policy experiments to try out new and innovative things. And they're not mutually exclusive. So I always recommend that if you are thinking about talking to your state about adding a Medicaid violence prevention benefit for your state, the best way to start is to start talking to your state Medicaid office, and they can tell you what the lay of the land is and what it would take to do something. They might be able to just add the benefit through their administrative process. In fact, some states have done that to get things started. Or they may be saying, we would need legislation or a bill to pass the state house to get this done. And if you start at the state Medicaid office, hopefully it saves you a lot of work and can avoid going down the wrong path to get things started.
Great, thank you. And I have another question. Someone in Milwaukee, the org is licensed and credentialed with Medicaid already, and they have a fully operational behavioral health clinic. And they ask, will this be helpful in this effort?
Yeah, I think what we know is that if you're a healthcare provider that is already um, knowledgeable and has the reps and is already doing medical billing, that you are already set up for success for when hopefully a Medicaid benefit comes down the line in Wisconsin. Um, Programs that are already doing the billing and have that infrastructure, you've already done the vast majority of the work. So if a new benefit comes online, the main things that you'll have to do is make sure that you have, the required training and certification for your frontline workers and required documentation to make sure that you're capturing things right. But you're already doing things and are most of the way there. Um, I, I think that this question kind of dovetails a little bit with another question someone asked in the chat about how are programs doing it? Are they doing billing in-house on their own, or are they farming it out to a third-party organization? And Roy, I want to pass it over to you to kind of talk a little bit about that. You guys elected to go with the third-party processor. Can you talk a little bit about what you guys were thinking about and how you made that decision? I think a lot of other people might be thinking about that too.
Yeah, and great question. And a great point about the proper documentation. And I kind of mentioned earlier that we wanted to err on the side of caution when it came to Medicaid because one, we knew we didn't have the internal infrastructure, meaning that we didn't have the experience in billing Medicaid. And so that's how we landed on, well, let's hire a third-party biller. But once again, I think it was important and crucial for us to say, well, we would like you to train somebody in-house so we can have the ability to bill Medicaid internally on our own. But a question was asked earlier about some of the challenges. What I can say, and I don't want to I don't want to gloss over this. There was a big learning curve for staff when it comes to one, us identifying a database that was conducive or that aligned with billing Medicaid and the third party biller. So these are all the things in the weeds that we had to meet about. Finding a database that we could use that one was seamless what we were already tracking, but also met the requirements of what the third party biller would need to bill Medicaid. And it was a learning curve for staff. We had to do a lot of training. This is a different approach to the way that we're tracking, doing our notes, and being detailed to meet Medicaid requirements. So once again, I encourage anybody who is looking at this to one, find a software or a CRM that is user friendly for you and your organization, but also spending a lot of time working with that software to train frontline workers. It's doable, it's a learning curve, but it's a certain professionalism and a different way of approach, a therapeutic um, conversation around how you're providing that case management.
And Roy, if I can add, I think another kind of piece, I was on the Medicaid side, and I think it was helpful with me talking to the third party biller to make sure that they understood with the organ benefit, you can receive services for up to 24 hours a day. And that is
Yes.
very different than most ways of billing Medicaid. So a lot of it was like, yes, you can do this, and here's why. The second piece of things is folks on our Medicaid benefit, the Oregon Health Plan, go on and off throughout the year, depending upon kind of if they're covered or not. So having a third party biller also helped track that because you could be working with someone the whole time, but you can only bill for certain chunks of it depending upon their coverage.
Thank you both so much. We have another question. So if you have hospital-based violence intervention program services or HVIP services, do you use a third-party biller for HVIP work or go through the hospital billing department? And if you go through the hospital, how does that money get to the CBO partners doing the work? Kyle, you have experience in this.
Yeah, I think the honest answer to that question is if you're part of a hospital, you're going to have to start with your own hospital's billing department first. Um, we have been exploring in organizations that have these hospital and community partnerships And we are still working with a number of programs to really kind of get the kinks out of that situation. But how most programs are thinking about it is there's one I'm thinking of in particular where the hospital has their HVIP and they have their community-based program that they have worked like hand in glove for decades together. And what they want to do is um, the hospital knows that they have the infrastructure to do the billing on their own, but their community-based partner, it would be a bigger lift for them. And so the strategy that they have come up with is for the hospital-based program to take on the billing altogether and to have a contract with the CBO and a memorandum of understanding so that the hospital can take the dollars in, separate which dollars are coming from the HVIP, separate which dollars are coming from the community-based organization, and then they can directly send a check to the community-based organization on their own. And so those are the type of partnerships that we think are going to have a lot of collaboration. It's going to take some effort and time to figure out what works best in your own community based on who you have on staff, who you have in community. Alternatively, we found that some community-based organizations sometimes it's a little bit easier for them than paradoxically, you would think that hospital-based programs would have the easiest time, but sometimes community-based programs have had a little bit more running room and a little bit more leniency to set things up because they know if they're working on it, they are the number one priority. Uh, in the organization. Whereas if you're going through the hospital billing department, there's you and surgeons and the emergency department and all sorts of different people that are using those same folks. So it really is has to be a local decision and have some flexibility and collaboration to work together, but it is doable.
Thank you, Kyle. And I just want to open it up and just ask if any of our panelists have any final remarks. Great. We have no more questions. Kyle, I'll hand it over to you. Or Louisa, did you have something?
I was just going to say again that I think it is helpful and important for folks in philanthropy to be hearing from those of you who are exploring this in your states. One of the things that we, at the Joyce Foundation, when I'm sitting with other funders, one of the things that we, are constantly trying to think about is, what does the field have capacity for? You are all doing so much incredible, tremendous work, and we don't want to get ahead of you. We want to support the field. And I think it's really important for us to be hearing where there's energy, where there's interest, where there's momentum, where aren't there learning communities, but should be. The work in Maryland and California has clearly been tremendously important in helping to turn those benefits into reality for those CBI ecosystems. So I just encourage folks, make sure that we know what we need to know about where you are and when you're ready and what would be helpful. It is, and again, super, super, just glad to see where Oregon has gotten, and really, major congratulations to you all at the HAVI for getting to this point with the guide. This is just such a tremendous resource.
Thank you so much, Louisa.
Roy, did you have something?
Yeah, I just wanted to add, I think once you do get to a place where you are billing Medicaid, just keep in mind that this is to support what's already being done. Because what we have seen is that people think because we are billing Medicaid and we have been billing it robustly, that they think that this is covering the true cost of doing HVIP work. And it doesn't. And so it was always envisioned to support the work that we're already doing. So also be strategic around double dipping. We met with several other states that had several concerns around other funding streams. So just be intentional. As we know, there is a lot of work that can be covered under this Medicaid. So once again, be strategic, intentional on what you're billing for, so it doesn't double dip. But also always advocate that this is only to support the HVIP work that we're doing because it won't cover the true cost.
Wonderful. Thank you so much, Roy. Thank you, Molly. Thank you, Louisa. Thank you, Khalees. And thank you in the audience. You guys are the ones that are here doing the work, and we really want to thank you so much for coming today. Um, we brought everyone together today because, obviously we clearly believe that Medicaid is an important opportunity to sustain the work of community violence intervention. But we know that implementation takes planning and organization and partnership and capacity building. And fortunately, you're not alone. We're all here together. We have a community of folks that are doing this work to help us learn from one another. This resource guide that we have released today is another tool to help in sorting this out and using this to help keep your programs going and to save lives. So please go to the website, download the guide, share it, connect with us at the HAVI for any other support or technical assistance, and please stay engaged. We are here to help both with Medicaid and getting onboarded with it, but also for any and all of your policy and advocacy efforts. So we want to thank you all for being here today. At the HAVI, we obviously believe that violence is preventable, and creating these new systems to keep CVI sustainable and fully funded, that this work saves lives and the work that you do saves lives. And that's why we are all here in a community together. So thank you for joining us today, and we will see you all soon. Thank you.